Hello and welcome to Talking About Tumors with Ryan and Ryan. I'm Ryan Holstead.
And I'm Ryan Quinn.
And we're back to start our two-part discussion around renal cell carcinoma. Today discussing the background in localized disease.
It's currently July 4th here in the United States, so happy July 4th to all of the Americans listening.
I think it's July 4th everywhere, but just a holiday in the U.S.
Exactly.
Renal cell carcinoma is an interesting cancer. It's less common than much of the other cancers we've discussed so far, but has been heavily studied because a lot of our landmark understandings of cancer and research around things such as the VEGF system and immune therapy sensitivity have really come out of research that had shown early inroads in the renal cell carcinoma space. This is a cancer with a very wide spectrum of behavior, and there's tumors that can be presenting very indolently, even left untreated, taking years before you notice detectable growth on CT scans, all the way to cancers that are rip-roaring extremely aggressive and can be lethal in a matter of months if left untreated. This cancer has been insensitive to chemotherapy over the years, and much of the discussion around systemic therapy will be on our novel targeted agents, as well as immune checkpoint inhibitors.
Renal cell carcinomas make up about 85% of primary renal cancers, and they occur in the renal cortex. The most common type is clear cell, which is about 80% of renal cell carcinomas, but there are also other types such as papillary and chromophobe. You can also see transitional cell or urothelial carcinoma of the renal pelvis, but that is treated more like urothelial cancer rather than renal cell carcinoma.
Generally, these cancers associate with obesity, hypertension, and smoking. However, these associations are relatively weak, and the exact causality is likely multifactorial. There are also familial forms that exist, the most common being in von Hippel-Lindau syndrome. The von Hippel-Lindau gene, or VHL gene, is a tumor suppressor. This familial syndrome is autosomal dominant and often will inherit one mutated tumor suppressor, and then at some point later in life, we will have loss of heterozygosity. It's also worth noting in non-familial renal cell carcinoma, the von Hippel-Lindau gene is seen mutated in greater than 90%. So it's thought that this is a significant driver. The mutation in von Hippel-Lindau leads to ineffective suppression of the hypoxia-inducible factor HIF. So basically the cancers think that we don't have oxygen coming, so they grow in order to try to maximize stimulation of things such as EPO, etc. VHL also associates with retinal angiomas, CNS hemangioblastomas, pheochromocytomas, and islet cell tumors.
Two other genetic syndromes can be associated with renal cell carcinoma: tuberous sclerosis, as well as the hereditary papillary renal carcinoma syndrome, which, as the name would suggest, tends to be associated with papillary renal cell carcinomas.
Interestingly, with the exception of tuberous sclerosis, both VHL and hereditary papillary renal cell carcinoma, which associates with the MET mutation, tend to lead to cancers developing later in life, such as in the 50s and 60s, which may be different than what we see in some other genetic syndromes, which tend to present earlier in life. Another less common familial syndrome, but one that is high yield in testing, is the FLCN gene, and mutations in this can lead to the BIRT, B-I-R-T, HOG, H-O-G-G, Dubé syndrome. This is an autosomal dominant syndrome associated with chromophobe renal cell carcinoma, which is typically thought to be a favorable pathology. Birt-Hogg-Dubé also associates with benign hair follicle tumors and cystic lung findings.
So in medical school, we learn about the classic triad of symptoms in people that are diagnosed with renal cell carcinoma, and that includes flank pain, hematuria, and a palpable abdominal mass. This is actually pretty rare these days, given the increase in imaging that we've seen. Many of these tumors are now caught incidentally on CT scans done for other reasons. And that could explain why the prognosis for these cancers has improved, because we are catching them at an earlier state. If we do have symptoms, and hematuria is the most common, tends to be because the tumor starts invading into the collecting system, can have pain, weight loss, which could be seen in people that have more advanced disease. Another classic internal medicine question is a male who develops a left-sided scrotal varicocele. And if you remember back from your anatomy days, on the left side, the testicular vein goes right into the renal vein, whereas on the right side, the gonadal vein goes right into the IVC. So if you have a left-sided testicular mass, it could block the venous drainage and cause a left-sided varicocele. So this could be a clue to a renal cell carcinoma on the left side.
Uncommonly, but can be seen, are some paraneoplastic syndromes. Most commonly, this would present as anemia, although erythrocytosis due to the von Hippel-Lindau mechanism mentioned can also present. Patients may present with fevers, hypercalcemia, leukocytosis, or thrombocytosis. And one interesting paraneoplastic syndrome is Stauffer syndrome, and this is transaminitis, an elevation of ALP, AST, and ALT, which can sometimes be quite profound, and maybe in rare cases may be the initial presenting factor for these cancers. The treatment for Stauffer syndrome is treating the cancer either surgically or with systemic therapy depending on the stage.
So once you have a suspected renal cell carcinoma, imaging usually includes either a CT abdomen pelvis or a MRI with a dedicated renal protocol to determine the local extent of the tumor.
Radiographic findings can also help with the pretest probability of determining if this is a renal cell carcinoma. Often the imaging will describe a heterogeneous exophytic mass in the renal cortex. These dedicated CTs or MRIs will help differentiate from a simple cyst or another benign lesion such as an angiomyolipoma.
Given the very suggestive clinical features, oftentimes there's a limited role for kidney biopsy in patients that are going to be going for surgery. There is some concern about seeding the peritoneum during a renal biopsy, as well as just generally low yield of the renal biopsy in these cases. So many times our urology colleagues get involved early, and the nephrectomy provides the treatment as well as the final tissue diagnosis. The staging system, similarly to other cancers, is the TNM staging system. The T stands for size, T1 being less than or equal to 7 centimeters, T2 being greater than 7 centimeters but localized to the kidney, T3 being any size but extending into the venous structures and perinephric tissues but not going past the Gerotis fascia or invading the adrenal gland, and T4 being any lesion that goes beyond the Gerotis fascia or into the adrenal gland by local invasion.
This may be described as retroperitoneal extension or hepatic invasion on the radiographic imaging.
The N and M is pretty simple. N0 being no regional nodal involvement and N1 being any regional lymph nodes involved. And same thing for metastatic disease. M0 being no evidence of metastatic disease, M1 being metastatic disease. The most common sites of metastatic disease are lung, bone, lymph node, liver, and adrenal gland. As far as the exact stages go, stage 1 is any T1 and 0, so any tumor less than or equal to 7 centimeters with no lymph node involvement. Stage 2 is T2 and 0, meaning any cancer that's localized, that's larger than 7 centimeters and localized to the kidney. Stage 3 being any T3 lesion, so anything that's invading into adjacent structures but not past the Gerotis fascia or adrenal glands, or any N1 disease. And stage 4 being any evidence of distant metastatic disease, as well as any T4 lesion.
As often when localized, these tumors can be somewhat indolent, slow-growing. PET scan is not necessarily always a useful test for these patients, so usually you'll begin with the CT chest, abdomen, pelvis, and consider bony imaging, especially if the patients are presenting with either an elevated alk phosphatase, hypercalcemia, or bony-related pain. Typically, bony lesions will be lytic. So the standard of care for a localized renal cell carcinoma would be surgical resection, and this is most commonly done with a nephrectomy. For very small T1 tumors, partial nephrectomy may be possible, but often this can't be determined until the time of surgery, once the surgeon has identified their surgical planes, and will depend on center to center and your local urologic oncologist's expertise on whether a partial nephrectomy is attempted. Lymph node dissection is not necessarily part of the standard of care. It hasn't shown to improve overall survival and does lead to increased postoperative morbidity. If a patient has pathologically enlarged nodes at the time of imaging, however, these should be attempted to be resected. Less than 5% of radiographically clinically known negative cancers end up being upstaged at the time of a lymph node dissection, partially justifying to avoid this procedure.
For small lesions, less than 3 centimeters, especially in patients that are not surgical candidates, you can consider ablative procedures such as radiofrequency ablation or cryotherapy rather than surgery. In these cases, although we said that biopsy is usually not indicated, you would consider a biopsy prior to the procedure.
It could even be possible to, depending on your system's capabilities, to do the biopsy, review the frozen section at the time of the procedure, and then proceeding immediately with the local ablation. although these procedures tend to be well tolerated. Risk of recurrence, even for those, given that these are small tumors to begin with, is fairly high, with recurrence being somewhere in the 10 to 20% range versus only 3 to 5% for a partial nephrectomy of a tumor of a similar size. Another option that can certainly be considered in tumors that are less than 2 centimeters, once again preferentially in patients who have other comorbidities, could be active surveillance. Approximately 20 to 30% of patients who undergo active surveillance for tumors less than 2 centimeters have stable disease even up to 2 years later. Surveillance following a definitive approach is guideline supported, although the evidence for the best approach to surveillance is a bit limited, and there does seem to be some variation between the different guidelines. In general, though, most people would recommend, given that we do have effective systemic therapy and options at the time of recurrence, would be to do cross-sectional imaging and blood work, somewhere between 3 and 6 months for the first 3 years, then every 6 to 12 months, up to 5 years. Beyond 5 years following nephrectomy, decision for ongoing surveillance will be a shared patient and physician decision. It should be noted that, especially in the more indolent tumors, these can begin to arise again in a metastatic state even beyond 5 years. So if you have a young healthy patient who you would consider treatment at the time of recurrence, it may be worthwhile continue with annual CT imaging. As far as imaging in the chest goes, either a chest x-ray or CT should be sufficient.
The most recent hot topic in renal cell carcinoma has been the use of adjuvant therapy to prevent recurrence after curative surgery. Given that over half of high-risk patients will have recurrence after surgery, mainly with distant metastatic disease, there have been attempts to look at the addition of adjuvant systemic therapy to reduce this risk. This has particularly been looked at in high-risk patients, such as patients with stage 2 or higher disease.
Up until recently, many attempts at trying to treat adjuvantly have been unsuccessful. We will go into greater detail on our systemic therapy options during our next discussion, but these fall into two camps in modern day management of renal cell carcinoma. One would be our TKIs, such as drugs like sorafenib or sunitinib that inhibit VEGF as well as other kinase targets, or the immune checkpoint inhibitors. Many of our treatment algorithms in the metastatic setting will combine a checkpoint inhibitor with a tyrosine kinase inhibitor. This would be considered the standard of care for the majority of patients with stage 4 disease. For many decades, trials have been reporting out attempts at using various TKIs or immune checkpoint inhibitors in the adjuvant setting, and these have all been negative. They've been negative for both disease-free survival and, more importantly, for overall survival. The earliest of these were looking at drugs such as sunitinib versus placebo. There's studies using everolimus, pazopanib, which is another TKI, which we'll talk about later, axitinib. In the best case scenarios, when the most high-risk selected patients, either those that were node positive or with other concerning features on pathology, we would be able to demonstrate an improvement in disease-free survival. However, none of these studies have ever shown improvements in overall survival, and even the disease-free survival improvements have been modest. When we're looking at the trials with immune checkpoint inhibitors, there are 3 negative trials that have incorporated these agents, one using a year of atezolizumab, one using a year of nivolumab, and even a study using both nivolumab and ipilimumab doublet immune therapy. And all 3 of these studies were negative for disease-free survival. The doublet immune checkpoint inhibitor did try to select more higher-risk patients, only including patients with PT2 or greater tumors, and still was unable to show an improvement in disease-free survival. So it was with some surprise and potentially reason for optimism when a positive trial using pembrolizumab reported out in 2021, which is Keynote 564.
Yeah, so this study was a phase 3 trial looking at about 1,000 patients with clear cell renal cell carcinoma who were status post either total or partial nephrectomy. And it looked at 1 year of pembrolizumab, so 17 cycles of pembrolizumab every 3 weeks versus placebo. The study included patients with high-risk disease, which they broke into 3 different groups. The first group was patients with what they called intermediate to high risk, which was the T2 and 0 patients. The T2 patients had to have either grade 4 disease on pathology or sarcomatoid features, which generally infers a poor prognosis, or they could be T3 and 0 of any grade or any pathology. Then they included high-risk patients, which were the PT4 patients, or anybody with node-positive disease. And then they also included a subgroup of patients that had metastatic disease that was completely resected and with no evidence of metastatic disease prior to enrollment.
So this is already different than the previous trials, which I didn't even really go into any detail on. All these studies were M0 patients, and this definition of intermediate to high and high risk are newer definitions, with the older studies typically using just increased T-score or node positivity to demonstrate whether or not a patient be a higher risk. It should also be worth mentioning that although sarcomatoid cancers are more aggressive, in the metastatic setting they've appeared to be more sensitive to immune checkpoint inhibitors.
The study excluded patients with brain metastasis that were resected, as well as patients who had bone metastasis that were resected. And patients had to be randomized within 12 weeks of nephrectomy. The primary endpoint of the study was disease-free survival, with overall survival being a secondary endpoint. And it was stratified by patients that had metastatic disease that was resected, ECOG status 0 or 1, as well as patients treated in North America versus outside of North America.
The trial protocol was written such that if disease-free survival was shown, that they would then convert the overall survival, which was initially a key secondary endpoint, into a primary analysis at follow-up publication. Due to this statistical gymnastics, the alpha to be a positive for overall survival had to be 0.0144, and it had 79% power to detect improvement in overall survival with a hazard ratio of 0.67.
So again, this trial included almost 1,000 patients, and looking at the patients involved, only 5% had metastatic disease that was fully resected. 86% were in the intermediate to high risk group, and 8% were in the high risk group.
10% of the patients had sarcomatoid features.
30% of patients were over the age of 65, and although PD-L1 status was not required to be positive for enrollment, this was essentially tested on everyone, and 75% had a positive PD-L1 using the CPS criteria.
70% of the patients were male, which is fairly consistent with the population that developed this cancer.
Looking at people that completed the study treatment, 61% completed the full 17 cycles of pembrolizumab, and 73% completed 17 cycles of placebo. The reason for discontinuation for the pembrolizumab group, most common reason was adverse events followed by recurrence, and in the placebo group, the majority discontinued due to recurrence. The primary endpoint at the first reporting of this was 24-month disease-free survival, which was 77% in the pembrolizumab group versus 68% in the placebo group. The majority of recurrences were distant recurrence, with 17% in the pembrolizumab group versus 23% in the placebo group. In terms of local recurrence, 3.4% in pembrolizumab group versus 6.4% in the placebo group.
These improvements in disease-free survival, although more pronounced in the M1 resected patients, seem to be persistent regardless of intermediate to high risk, or M1 disease.
Looking at adverse events, 21% of patients discontinued due to an adverse event in the pembrolizumab group versus only 2% in the placebo group.
And that the updated publication, which we'll get to in a moment, looking at overall survival, grade 3 toxicity was reported higher at 30% versus 18% in the intervention versus placebo group.
At the most recent updated analysis, with a median follow-up of 57 months, the 4-year overall survival was improved with the addition of pembrolizumab, 91% versus 86%. And this was irrespective of the intermediate or high-risk subgroups, or the M1 versus M0 subgroup.
For all comers, this led to a hazard ratio of 0.62, and for the M1 patients, this gave a hazard ratio of 0.52. Although survival seemed to trend favorable in all the major subgroups, it's worth noting that the United States overall survival did not appear to be statistically improved in that subgroup. So this did translate into a significantly improved overall survival improvement, roughly calculates the number needed to treat to 20. Of course, one of the most important things when we're looking at adjuvant therapy is whether or not patients are, at the time of recurrence, are receiving any further therapy. Because ultimately we're treating with a drug that we've been using in the metastatic setting and trying to incorporate it earlier on with the hope that we're going to cure more patients. Because of that, the subsequent therapy does matter. In 80% of the patients in the placebo group who did recur, some form of therapy was administered. 20% of this was radiation. 29% of this was subsequent surgery. And 84% of all the patients who recurred got some form of systemic therapy. 70% of the patients who received systemic therapy received an immune checkpoint inhibitor later on. However, it's worth mentioning that this only translates into 59% of the patients recurring, receiving some form of PD-L1 inhibitor at the time of recurrence.
Due to the study, pembrolizumab has been approved in the United States for adjuvant treatment in patients who meet the criteria for the study. So patients are intermediate to high or high risk, or patients with fully resected M1 renal cell carcinoma.
Understandably, there was a lot of excitement when this study was published, especially given all the negative pre-existing adjuvant therapy trials. Of course, that also raises some questions. Why was this study positive and the others weren't? There was other immune therapy studies that had similar patient populations that had absolutely no difference in disease-free survival. It could be by enriching the patient population with only the highest risk, and I think it's very helpful that we've now kind of demonstrated some higher risk features and criteria that will help select the patients, if at all, that we're going to either enroll in these trials or consider for adjuvant systemic therapy. A couple caveats, however, quite a number of patients did not recur. So although there was an improvement in survival of approximately 5%, the control group still had 86% overall survival at 4 years. This is different than, let's say, in adjuvant lung cancer, where an absolute benefit of 5% was shown, but the median overall survival at 5 years for the patients not receiving adjuvant therapy is 50% or less. So we're dealing with a less dire cancer and administering a therapy that could have significant toxicity to a number of patients who may never recur anyhow. Also worth noting, in the pembrolizumab arm, even at 4 years out, we do continue to see a general decline in the disease-free survival. These curves do not necessarily go flat. So it may be possible that the pembro is just delaying recurrence rather than curing patients altogether. And if that's the case, then it's very important that all the patients on the control arm who do recur are exposed to immune checkpoint inhibitors. And unfortunately, a probably lower than desired number of patients on the control arm eventually had access to pembrolizumab. And that might have been because it was not mandated in the trial protocol. And with a global study, many of these patients may not have had access to it. With that all being said, I think if a patient is high risk, it's certainly worth having a conversation about them, whether or not this would be something that would be in their interest. There are some nomograms that help also predict patients' recurrence risk. I've been told the Fox Chase nomogram probably has some of the most up-to-date data based upon the ASSURE trial using one of the TKIs. And this takes into patient characteristics to determine what their DFS, their disease-free survival and overall survival would be based on at 4 years to help try to risk stratify. And you can use this along with those high-risk features that were used in the KEYNOTE trial.
So I guess it's time for bottom lines. So renal cell carcinoma is the most common primary renal cancer, and nowadays is often detected incidentally during imaging done for other reasons.
There are some high-yield familial syndromes that you should be aware of, most commonly being von Hippel-Lindau, and also worth noting that greater than 90% of all renal cell carcinomas express at least one von Hippel-Lindau somatic mutation.
Clear cell is the most common pathology, followed by papillary and then chromophobe. And sarcomatoid features tend to be a poor prognostic factor, although it has shown to be more sensitive to immunotherapy.
If you're staging workup, including a CT and a dedicated CT abdomen or MRI abdomen looking with a renal protocol, are negative for distant disease, the standard of care would be a radical localized approach, such as surgery, or if patients are frailer and the tumor is less than 3 centimeters, radiofrequency ablation or cryoablation could be considered. For very small tumors less than 2 centimeters, active surveillance may even be in your patient's interest.
Many patients, particularly those with high-risk features such as node-positive or T4 lesions, will recur after surgery, mainly with distant metastasis.
There have been many attempts to incorporate adjuvant therapy to improve on overall survival in this patient population, all being negative up until the recent KEYNOTE 564 trial.
KEYNOTE 564 did have an improvement in both disease-free survival and overall survival with the addition of 1 year of adjuvant pembrolizumab, with the 4-year overall survival improved from 86% to 91%.
This trial included only patients who were determined to have either intermediate to high risk, which would be T2 tumors with sarcomatoid features or grade 4 pathology, T3 tumors, and also included a percentage of patients who were metastatic with complete resection.
The marginal improvements in overall survival did come at a cost of toxicity, with approximately 30% grade 3 toxicities in the pembrolizumab arm.
And we should always remember that pembrolizumab toxicities can become life-threatening or can be permanent, such as things as hypothyroidism, which may be a nuisance, or type 1 diabetes, which can be more than a nuisance.
That being said, pembrolizumab is approved in the United States for patients with intermediate to high-risk disease or patients with metastatic disease that has been fully resected. So it is an option for these patients. On that note, hope everyone is having a good summer. Thanks for listening and take care.
Bye for now.
For more information, follow us on Twitter at Talking Tumors or feel free to email us at talkingabouttumors@gmail.com.
Please rate and review the podcast. We really appreciate it.
And special shout out to our friend John Kim for all of his musical talents.
And he is the composer of the music that you're hearing right now. Talking About Tumors is not medical advice.
For medical advice, please contact your own healthcare provider.
Opinions stated on this podcast are by the Ryan who said it and no one else. We have no financial disclosures, and this is done purely on our own time to the sake of our enjoyment of the field of medical oncology. Thank you for listening, and see you next time.